Okay, yeah,
Great.
whenever you'd like to start, I think we're ready.
Thank you. Yeah, and thank you all for spending your time here to learn about our work. So I'm Andy Tatem. I'm a professor at the University of Southampton, and I lead the WorldPop research group. Also here with me is Natalia and Winfred, who are going to be around to answer questions in the chat, but also to present some of their work. Unfortunately, Christina, who leads our work with Countdown, is unwell today, but she will be someone that many of you know and have seen on meetings, and will be hopefully better soon to answer questions and be available. But so I'm going to give an overview of our work in the WorldPop research group, and in particular those areas that we provide tools, support, and relevant work for the Countdown program. So to start with, we are an applied research group at University of Southampton, and we focus on integrating different geospatial data sets to try and improve the timeliness and spatial detail of data on population counts, their demographics, their characteristics, and also some areas about mobility. And a lot of the background information and things I'm going to talk about you can find on the WorldPop website that's linked there. So we have a strong focus on research and producing open and peer-reviewed methods and data sets. On our website at the moment, you can go and download as many as 44,000 different data sets on population counts, characteristics, and I'll go through some of those today. We also increasingly provide different types of portals for you to interact and download those data sets, and applications to explore, interrogate some of those data sets that we produce. We have a strong focus on working with governments, UN agencies, other end users on actually implementing and tailoring the types of methods and analyses that we produce. And importantly, strengthening local capacity to utilize these data sets and develop those methods within governments or within other agencies. And that's something we'll be talking about today as well. So in the area of reproductive, maternal, newborn, child and adolescent health, our work over the past 5 or 10 years has focused on this chain of data sets, really. Firstly, the basics of mapping populations by age and sex, then breaking those down to get to key population groups, so that's pregnancies and births. Then the physical access to health services, the travel times, analyzing utilization, and yes, the final part, mapping that actual service utilization. So we'll go through some examples of work on each of those in the next 30 or so minutes. So firstly, this basic component of mapping populations by age and sex. So I'm showing you here is a giant data sandwich. In reality, those layers look a bit like this. We are taking different geospatial data sets that represent different characteristics of the landscape and the populations. So that can be the traditional forms of demographic data that can come from a census matched to the boundaries where that enumeration had taken place. It can be coming from household surveys and the location of those clusters of the survey where those questions were asked, or it could equally come from health facilities themselves geolocated and the data that are being collected at those facilities. It can be information about the infrastructure of the country, so the location of health facilities, the location of road networks, paths, and urban and rural locations. And increasingly, that kind of data is becoming better and better. We work with data sets across sub-Saharan Africa of mapping individual building footprints nowadays to try and improve our mapping of populations. And we also work with some quite new forms of data coming from things like mobile network data. So the movement of populations based on estimates, aggregate estimates from the movement of mobile phones. What we do is try and bring these all together to produce gridded outputs. So what we mean by gridded outputs is dividing the entire world into, in our case, either 1 by 1 kilometer or 100 meter grid cells. This gives us a consistent, comparable format for integrating different types of data. But it also gives us that flexibility to summarize to any administrative unit level. And often decisions are made at either the district or provincial level. So we can do our analysis at this fine spatial scale where we can integrate different types of data, but we can aggregate up to provide outputs at these administrative unit levels. An example of this here is taking estimates, gridded estimates of women of childbearing age per 1 by 1 kilometer, overlaying the location of comprehensive emergency obstetric and neonatal care facilities. And by doing that, we can then analyze those data and provide outputs in multiple different formats, depending on the need. In this case, we can summarize by administrative unit in Ethiopia, the Woreda, and we can summarize by looking at the percentage of women of childbearing age that are within 50 kilometers of one of those facilities with comprehensive emergency obstetric and neonatal care to provide an illustration of where those gaps are. So what we do in terms of population estimates, this is data that we have readily available and free to download on our website, where we've taken the most recent census counts or official projections and disaggregated them to a grid square level. So you can see here, this is northern India. This is estimates of populations, numbers per 100 by 100 meter grid cell in 2000, in 2010, and 2020. And so we're utilizing data that comes from satellites that map the changes in settlements and a range of other geospatial data sets to produce these more consistent estimates of population. We also bring together sources of data on age and sex structures. So this can come from censuses, household surveys that are matched to the relevant boundaries, or from census microdata or a range of other sources. And in this demographics portal, you can explore some of those data sets. And the aim here is really to start to dig down to those subnational inequalities that often exist. We also do a lot of work in terms of populations on working directly with national statistics offices, in this case through the Grid 3 program, to produce estimates in the absence of census. So in some countries, there have not been a census for 20 or 30 years. In other cases, the most recent census has become outdated. There's been a lot of population movements or growth around urban areas. And so this is working with more recent survey data and developing statistical models to estimate population, importantly with uncertainty around those. And I'll talk at the end about the ways those data can be accessed. So I will hopefully be able to hand over to my colleague Natalia, who has led our work on mapping pregnancies and births. Natalia?
Hello, can you hear me there?
Yes, go ahead.
Thank you, Andy. So yes, so a lot of our work in recent years has been focusing on mapping births and pregnancies. So can you pass next, Andy? Or do I? Yeah, thank you. In order to do this, we have used population mapping, as Andy has mentioned before, and with addition to identifying the age structures to identify the women of childbearing age, as you can see in the second panel in the slide. And then we were able to identify the women of childbearing age at the 1 kilometer, 1 square kilometer. And by using different type of fertility data, normally as they come as in administrative units, we were able to map the births, and by using a data from the Guttmacher Institute, we were able to identify the pregnancies where we had data on miscarriages, stillbirths, and abortions. Next, please, Andy. So as you can see, we were able to map births and pregnancies, births on the top and pregnancies at the bottom, across low and middle income countries at the square kilometer. Next, Andy, please. Additional to that, we have been using some Bayesian statistical modeling to predict the prevalence of adolescent birth in countries such as Kenya, Uganda, and Tanzania. In this example, you have in the exhibit A, the women of less than 16 years old, and in the middle, you have the 16 to 17 and 18 to 19-year-olds. Next one, Andy, please. And with this, we have been also have worked a lot on accessibility and indicators to specifically to health services, access to health services. Next, Andy. So we have used the travel ease. In here you have an example of 3 East African countries for which we have worked with the East African community. Next, Andy. So in combination with the location of health facilities, we have been able to identify the ease of travel, the travel times to health facilities. Next, Andy. This has also been carried out in the Pacific Islands in 15 countries. We have been able to use the travel times by walking, as you can see on the right-hand side, and then in the middle you can see the motorized travel times, and then we were able to calculate the proportion of pregnant women living within 2 hours travel time of a hospital. This was published in a report on the state of the Pacific reproductive, maternal, newborn, child, and adolescent health workforce. Next, Andy, please. Additional to that, we have been mapping the travel times to hospitals, health centers, and clinics, as you can see here in the 3 exhibits. Next. And this, we have been using it to estimate the access to birth and services for pregnant women. In here, you can see on the left-hand side that the travel times and the health facilities and the pregnant women. And with these 2, we have been working to measure the availability and the geographic accessibility to maternal health services. Next one, Andy, please. So in here, we have looked at 2 international indicators. So in the top, we have access to a target that is one comprehensive health facility for every 500,000 population. And in the bottom, we have a target that was to have at least 80% of the pregnancies located within 2 hours travel time to a nearest hospital. In here, what we did is we were looking at the different administrative levels. So we have a national level at the first administrative level and the second administrative level. As you can see, and at the national level, all countries seem to be achieving these targets. However, as you look at them, at smaller administrative units and districts, which is the last map, you can see that there is a lot of disparities here, and you can see that a lot of administrative units do not meet these targets. So now I'm gonna pass to my colleague Winfred, who will talk about some additional work that we have been doing.
So continuing from there, we have been combining the population data with other survey and census data. So far we've talked about combining among emergency obstetric care census data with our graded population surfaces. And in this example, we added the DHS survey. So usually when you use the DHS survey, we are not able to analyze access to services very efficiently. Or if we do, we assume that every woman goes to the nearest health facility. But we also know that a lot of people do bypass health facilities, which we would look at later. So in this example, we took data from health facilities. Again, many studies model access to all health facilities because we are not really sure where there are birthing services and where there are not. But in this example, we had access to routine health data, which showed us exactly where health facilities were being used and women were going there to give birth. We combine this with the emergency obstetric care census in Ghana. So near the DHS clusters, we are able to know the type of quality available to women. And then on top of that, we also knew we were able to know the number of the quality of services available to women. And we also quantified the travel time to services. So we knew how far these clusters were from health facilities. And through that, we're able to predict the probability of a woman having a skilled attendance at birth. And this probability would not also be very useful if we do not weight them, because again, births do not happen everywhere, and then the number of women everywhere are not equal. So we use the population surfaces again to weight our probability. So in this example, we're able to combine survey data set, health facility data, among surveys, and travel times into one analysis process, and then estimated the probability of a woman having a skilled attendance at birth, considering if we are modeling it to all health facilities with midwives or where births are occurring, and also comprehensive facilities. Next slide, please. And then this other study we did, in this case, we extracted data from registers. Again, if you compare to surveys such as the DHS, you are not told where women actually came from and where they went and gave birth to. So many times we assume that, again, every woman gives birth from a cluster, gives birth at the nearest health facility. But if you take routine health data, which in this case we did, we took the registers, which was actually already entered into the DIM software in Ghana. So we took that data, and from that primary data, we are able to know every health facility that the woman went to and which community they came from, generalized at a level where we don't invade their privacy. So through such a rich data where you know where women come from and where they go to, you are able to map out their flows, their movement patterns across space. And then you are also able to quantify the bypassing of health services, because you know on their way from their community, wherever they came from and where they bypassed and where they went to. So from this analysis, we actually realized that women were traveling about approximately 5 more kilometers to reach the health facility where they gave birth to, and rural women were traveling more than urban women. Again, we were also able to quantify bypassing because we knew exactly where the women were going to. So about 5 out of 10 women were bypassing the nearest hospital to give birth at another one. But if you take into account the overall all facilities, then women were bypassing, about 7 out of 10 women were bypassing. So the first chart that map that we saw was the lines were very short. So it showed that the women were traveling very short distances. But the next one shows you if again you assign each woman to the nearest hospital, ideally, how long would they travel? So you'd see that these lines are a little longer than the previous one we saw. And then the third one shows you the real pattern of travel. So the one you are seeing on your screen now shows you the analysis of over 20,000 women from the routine data, and it shows you where they came from and where they went to. And from such an analysis, you can start making inferences to the movement patterns of women, reorienting services, and improving the quality of maternal and childhood at different locations. This is just the pattern, but behind this, we also did a spatial interaction model. So we combined this data with the graded population surface. Again, we combined it with the IMON surface. So we predicted the probability of, or the count of women giving birth at a certain location, taking into consideration the demand for services from the community they are coming from, the distance between their community and the health facility they went to, which we calculated as a straight line distance, and the quality of care at the hospital, because again, we knew exactly where they went to. So we're able to model the count of women considering factors such as quality, demand for services, and the distance between the women and the facilities they went to.
Thanks, Winfred. So yes, I think so far we are, I guess, covering a lot of presenting what is potentially possible. It's important to note with all of these that the input data is vital. So what we potentially can do, and this is similar to what Winfred just showed us for Ghana, where we have geolocated data from household surveys, we can move from the aggregate provincial level measurements of access and utilization of care to, in this case, working with the Open Health initiative of the East African community to look at district level estimates of things like skilled birth attendance, antenatal care, and postnatal care, where those data exist on multiple time points. We can look at the changes in those patterns of utilization. So here we see those trends for Kenya across a 10-year period, and the change in skilled birth attendance, antenatal care, and postnatal care. Where data exists on things like C-section prevalence, we can produce these estimates. Importantly, there's uncertainty in those estimates. When you're making estimates at small scales, there's producing a lot of prediction into unsampled areas, and so there's uncertainty in those estimates. Again, this is something that we do at the Data Analysis Center for Countdown and Geospatial, and is something where we can provide advice and support. We're also in a forthcoming work in a special issue looking at the possibilities of using alternative denominators for coverage estimates. So this is an example from Zambia, where there's in immunization coverage, there's often the challenge where doses are measured for a district, and then the denominator comes from projections from the census, which has a lot of uncertainty and produces often situations where you have over 100% coverage rates because projections have produced too low or too high numbers sometimes. So this is comparing different ways of estimating those denominators from surveys, from modeled estimates, and from satellite data, and seeing if those improve things. So as I've mentioned, there's a lot that potentially can be done, but to keep in mind the suitability of these model data sets for estimating indicators is very context specific. There's a need for availability of quality input data that should ideally be recent. The models that are being produced don't always fit well, and not all the methods that we're showing here produce uncertainty and estimates of that. So just to continue the overview, there's the final two sections. I'll talk about engagement and the capacity strengthening that we've done in the past, and also then the kind of data sets, tools, and training that we provide in the group. So these kinds of data sets are I guess, are starting to find their way into international reports in analysis of health indicators, in metrics and strategies for disease elimination, for access to healthcare, as Natalia said. Also in mapping physical access to care in humanitarian situations, estimating here the travel time to reach a health facility in Yemen or across Papua New Guinea. For estimating the coverage of interventions. So this is work in Nigeria, looking at the coverage rates of childhood vaccination before a supplemental immunization activity for measles, and then afterwards, again, based on geolocated household surveys. Some of the population data sets are now being integrated into the DHIS2 health information system of gridded data sets that can be used in the GIS modules that are being developed for DHIS2. And we have a range of different options for capacity strengthening in terms of courses. We're aiming to put together basic webinars on the kinds of methods and data sets that we produce. So this is again an example from the work with the East African community in producing these district level estimates, skilled birth attendance in this case. So there are already a range of data sets, tools, and background materials, and the appropriate ones very much depend on conversations that we can have, and there are a range of different levels depending on the skills that are already in place. So firstly, there are of course a range of academic publications for everything that we presented here that give far more detail than we have time for here. There's a special issue that we recently edited that brings together many of the kind of cutting edge methods for reproductive, maternal, newborn, child, and adolescent health in terms of data integration, geospatial methods, and some of the work that was presented. We have a page with webinars from across the WorldPop group in terms of the different methods and applications, but also many of those we're going to put onto the countdown page and also record specific webinars on accessing, downloading, and utilizing geospatial data sets. There are a set of applications that should be relatively user-friendly to be able to access and explore the data sets that I've presented already. So that can include basics that are data portal, so that you can explore different population counts and download those data sets. Similarly with age and sex structures, there's population demographics. It can also include some of the work presented on population estimation. So this is again the Zambia denominators data, where you can define a specific area or an age and sex group and obtain those estimates, download those estimates. And each of these data sets are produced in collaboration with a National Statistics Office. So an aim of a lot of this work is to work closely with those end users to make sure those data sets are utilizing the most recent data and are meeting those needs. We also have apps. If there is a need to produce your own rapid population estimates, you have access to data sets that, for instance, new census data that are matched to boundaries that you cannot share, or you need a quick estimate and you have survey data, new survey data that gives information on people per building, or housing units per residential structure. There are tools available to produce your own denominator data sets. On our website, there are, as I mentioned, there are many of these data sets that are available to download. Those are in geographic information system format, but also they come with increasingly with other types of format. So if you're not familiar with GIS, but you are familiar with just text files and can work with those, then we provide XYZ text files of those population estimates. We have our open population repository where we put some of the newer estimated data sets, and those all come with full documentation, background information on the data that's gone into them. And getting towards the more technical end of the spectrum, for those of you that are familiar with GIS programs, we have a range of different plugins that can go into open GIS software to enable you to more easily download, access, and use some of the geospatial data sets we presented. And for the extreme end of the technical spectrum, most of the code that we use to produce these data sets is freely available to download. There are frequently asked questions on our website about using those data, downloading the data, what kinds of software are needed to access them. And then what's actually coming next in terms of some of the work that we'll be doing generally in this field is continuing to refine some of these methods and data sets that we've produced, improving that mapping of access, bringing in other factors, so the quality of healthcare, the demographics, the push-pull factors as to why something may be utilized more than not, and mapping and modeling those new metrics. Specifically within Countdown, there is going to be a big focus here on improving our metadata documentation, but also we're starting to put together outreach and dissemination how-to videos. And we really appreciate and be excited to talk with many of you about what you would really benefit from seeing in terms of understanding how to produce your own data sets, how to utilize some of the ones that we make available already. But that's something we're happy to discuss. And we are leading the engagement for Ghana and also supporting the engagement in Kenya. And as I said, advice on model data, geospatial analysis. We are here to support you all with that, these types of analysis that I presented. And the research area, we'll be focusing on thinking about district level analysis and the suitability of some of these model data sets for estimation of utilization indicators. So I think that's really a rapid overview of a lot of the things to give you a flavor of the kind of things that we're doing. And I think this is really the start of the engagement here, and I'm happy now to hand over and for the next 20 minutes answer questions, discuss where this kind of approaches and methods can be useful. So I will stop sharing my screen and happy to answer questions.
Thanks a lot, Andy. Could you hear me? This is
Yes.
Sheikh. Great, thanks. This is a great presentation, and We really appreciate you going very deep into this. And I know most countries will be using this tool. I'm not sure who among your team is online, probably to add anything that you may add, but we would like to spend a few minutes asking more questions, engaging with country to see how we could help them, how we could be really useful to them during their reviews. Is there anyone from your team who have anything to add before we open to countries, Andy? No?
I don't think so. As Winfred and Natalia and myself are here and ready to answer questions.
Great. So let's open the floor to countries. And I think Tis also is on board, and feel free to chip in, Tis, if you have anything to clarify. Otherwise, we would like to spend a few minutes with the countries, maybe to know more about what they are doing. And there are also some questions on the chat that will be important also to consider. I've seen some questions. Tis, are you okay?
Yeah. No, I think thanks very much for a great presentation. And I think as Sheikh said, there are some interesting questions in the chat box. I think there's one from Niger, because you say your examples are all Ghana, Tanzania, and so on. What about us? And do the countries have actually equal opportunities to get into geospatial analysis? Do you need certain data that some countries don't have and others? So I think that's one. And the second one is whether or you could talk us through an example a bit more to show what the data needs are to be able to do that. For instance, you showed a cesarean section in Tanzania, or maybe something on immunization in Ghana. If you really go to district level, which is where we're focusing on for annual reviews, what kind of data do you need? Because we know surveys don't have district data, but you seem to have everything. So how did you get that?
Thanks. Yeah, so I can start with the Niger versus Ghana. I mean, I think it's very feasible to do a lot of these analysis everywhere. There was that slide about the big but. It needs a certain quality and type of data. The analysis I presented were examples from Ghana, because we have at Southampton long-running collaborations with Ghana, and hence Winfred is here with us. But that doesn't mean that we cannot work with other countries, and there are many examples as well of analysis across multiple different sub-Saharan African countries. And so, yes, when we're thinking about producing estimates of an indicator at the district level, so for example, what was done, example in the C-section analysis for Tanzania, the demographic and health surveys are not designed with their sampling to be able to summarize at district level. The sampling frame is for summarization either by urban or rural, or for provincial level. But over the past 10 years, there's been a lot of development in these geostatistical modeling approaches. They've started, first of all, in the world of mining, where you were actually trying to find where you could dig for gold, but you could only dig in a certain number of places. You could only sample in a certain number of places. So these were methods that were developed to try and predict in unsampled areas where you were most likely to find gold, to make people rich. But they started to then spread to other health, into the world of health and health indicators. So there's been a lot of work in the malaria field of taking surveys from either health facilities or in the community of prevalence of malaria, and looking really at the features of those locations. So do rural poor areas with poor access that are very remote, they tend to have higher rates of malaria. Areas with high rainfall, high levels of temperature to be suitable for malaria transmission. And that means once you can build those relationships at the scale of where those communities are, so you have a set of household surveys that have been GPS located across the country at the community level, and you have measures that correlate with prevalence of malaria, you can then start to build a model to look at, actually, we can predict levels of malaria. If we leave out some of those household surveys, we can see how well can we predict the rate of malaria. And across the years, this has been shown to be something that can be done and has started now to extend to other indicators. So things like, as we've shown, C-section, skilled birth attendance, are things where we start to bring in demographic characteristics from those household surveys, from geospatial indicators on remoteness and travel time. We can actually do a good job in predicting. Importantly, it's not perfect, and that's where the measurement of uncertainty is an important part of all of this. So that we can go from, we can produce these estimates at a district level, but they have confidence intervals on them. And those locations that have very few bits of data and have poor fit in the model, then those uncertainty levels are high. But this is something that there's an increasing amount of evidence and application of use to provide estimates at those district level scales. And so I think that it's something that we can put together is one of these webinars to describe this process in a bit more detail. There's already some academic documents, but something that puts together this in a more step-by-step analysis is something that we'll be focusing on. If Winfred or Natalia, you want to add anything?
Okay, thanks, Andrew. And I think even from the chat, there are some very great questions that have been asked there, and I've seen even Winfred answering some of them. And I see one from Advocacy who talk about trends and trend thing. I mean, if you want to do trend analysis with this, let's say over 10, 20 years, how do you do that? And I think Winfred tried to answer that. But if you want to chip in and clarify more, just do that. And also one other one is when you are trying to do that in countries where subnational units have changed over time, how do you do that? What will you consider? And I think that's a question from this island, which is very important. You may want to also answer. But let me say a few words in French also, because I want to engage more with the other francophone countries. Mes frères, je pense que les autres pays sont là et je pense que c'est important. Et tous ces pays-là sont à différents niveaux des analyses. Certains vont commencer les revues, certains sont en train de le faire. Et donc, il est important peut-être que si vous avez des questions spécifiques, je sais que la Côte d'Ivoire a déjà un plan, ils sont peut-être en train de planifier, peut-être c'est le moment de voir quels sont vos besoins réels et qu'est-ce que vous avez envie qu'Andy clarifie pour vous. Et peut-être la même chose également pour d'autres pays. Donc, je ne sais pas si vous avez des questions ou bien des clarifications spécifiques dont vous avez besoin. Côte d'Ivoire, ça va? Burkina Faso, Niger, ça va? All right.
Allô?
Yeah, oui, allez-y, Boubacar.
Oui, bonjour, c'est Aboubacar. Je me présente, je suis l'officier de liaison pour le mécanisme de financement mondial JFE, ici au Niger. Merci d'abord pour ces présentations qui nous ont été faites, qui sont très utiles en matière de santé de la mère et de l'enfant. Je pense que j'avais posé une question dont j'ai déjà reçu une réponse, parce que j'ai vu que presque toutes les analyses sont centrées vers des pays anglophones. Et je sais qu'en matière surtout de fécondité et d'accouchement, ici au Niger, je pense qu'on est champion en matière vraiment de fécondité et de tous ces problèmes qui ont été soulevés par-ci, par-là. Et je me demande alors, on a besoin quand même que ce genre de type d'analyse qui ont servi d'étude de cas dans les pays anglophones soit réalisé dans nos pays, parce que pour parler des différents thèmes qui ont été développés, d'abord en matière de recensement, je ne pense pas, nous on n'a pas un problème de recensement général de la population, je pense qu'on arrive quand même à répéter vraiment l'exercice presque tous les 10 ans. Le dernier recensement général de la population date de 2012. Donc, le reste des années, nous faisons des projections pour les populations. Mais quand même, en matière de naissance et d'accouchement, je pense qu'il y a lieu que vraiment une collaboration s'établit entre vraiment les experts qui viennent de nous faire cette présentation pour que quand même nous puissions améliorer surtout les données que nous recueillons du niveau périphérique district jusqu'au niveau national. Malgré qu'aujourd'hui, on a une plateforme, le DS2, qui est là, mais dont la fonctionnalité jusqu'à présent demeure un peu faible. Donc, je me dis que alors, quel type de relation ou qu'est-ce qu'on peut faire pour quand même tisser une collaboration avec les experts pour que le Niger aussi fait partie quand même de ces différentes analyses très pertinentes aujourd'hui qui va nous aider vraiment à améliorer nos indicateurs en matière surtout démographique, mais aussi en matière de santé de la mère et de l'enfant. Merci beaucoup.
Merci beaucoup, Aboubakar. Je pense qu'Andy a pris note de vos préoccupations, comment réellement être plus concret, engagé avec les pays. Alors, je sais que j'avais parlé de la Côte d'Ivoire, d'autres pays, mais s'il n'y a pas de questions, je pense que I think the questions that they already on the chat are very important to address, and I think maybe Andy could take some of them, probably to see how to get them. And the point of with further engagement, concrete engagement with Niger and other countries, I think is really open, and we've said that in other DAC session also, that the team are really committed and fully available to really have specific engagement with all countries to help them move on. But let me leave it to Andy and team to maybe pick a few questions, the one that are on the chat and the one that I already mentioned now.
Yeah, so I'll just help and answer the first two that you referred to earlier. So in terms of the trend analysis, we have data in Ghana, I think going back to about 10 years when we started using the DHIS in 2010. So I should mention that before coming to Southampton, I worked as a public health information officer with the Ghana Health Service. So I was one of the people actually entering this data on weekly and monthly basis. So it gave me a very deep insight to where the data is and the assumptions we make in collecting such data. So maybe 10 years back, the data might be a little patchy because we started learning with time and then we improved the quality of the routine data. So yes, we can do some trend analysis, but it also takes a lot of effort considering how much of the reprocessing and the cleaning of data that you'd have to do. On the next one, which is the subnational analysis. So when we do such analysis, we use the boundaries of countries to estimate the denominators or population and the various demographics and estimates that we make. So when when the boundaries change with time, you'd use the new boundaries for your aggregation. So the GIS processes that we use inherent in it is quite dynamic in the fact that your estimates would be very much up to date depending on the currency of the boundary layers that you are using. Yeah, I'll leave the collaboration ones to Andy.
Yes, on collaborations, yes, let's discuss what's possible here. Certainly for Niger, I mentioned the Grid 3 program, where we have support from the Gates Foundation and UK Foreign and Commonwealth and Development Office to support national statistics offices across sub-Saharan Africa with particularly with population estimates. And there we have just worked with Burkina Faso to help them fill in gaps in their enumeration on their recent census but also are starting estimation work with Niger. So I think this is where we need to link up different connections, but there is work ongoing to produce population estimates in Niger based on a range of different surveys that are going on. So I'm happy to follow up afterwards on that. And it's often the case that we are supporting across multiple projects, and this is something that we can bring into Countdown as well, because there's complementarities between the different projects and the kind of work that we're doing.
Great. I think that's fine.
Hello?
We have a question from Seth.
Yes. Thank you for a great presentation. Yes, I saw on the slide capacity building for Kenya and Ghana. I just want to find out whether it is up and coming capacity building or something that has already taken place. Over.
So this is for Kenya and Ghana. We're I think right at the start. Natalia, maybe you can talk about what has been done already for Kenya, and maybe Winfred as well. I guess you're more involved in the Ghana engagement.
So this is for the capacity building that we've done previously to. So we were training. Sorry.
So far for Countdown.
Oh, for Countdown, yes. So we have done a QGIS training, and we have done as well a data training. So it was an introduction to QGIS, and for state as well was an introduction to Stata.
Okay, thanks.
So what we are trying to do now is to try to prepare some of these materials that were provided for this for Kenya, to try to make them available as tutorials online, and perhaps as a short videos that will be posted on the Countdown website. So we're working on them. And additional to that, I was going to mention that we are now looking into doing some small tutorials to make them available. So if you have some suggestions or specific topics that maybe we can come together, that is something that really interests someone, we can look at things that we do, that we can provide the training on them. So yes, we're gonna do QGIS. We are also looking into possibly doing an access mod to calculate travel times to health facilities, and how to incorporate births, pregnancies, or population data on them. So that is there are a couple of them that we are already thinking of. But again, if there is a consensus and if you have some ideas of things that you think will be useful, please let us know, and we can try to incorporate your ideas. Thank you.
Yeah, that is fine. But what I want to know, who are the target people who are leading this? I am here, I'm part of the Countdown, but I don't know about this. That is why I'm asking. So if it's something that is up and coming, then probably we need more information on this and then how to prepare and get it. I'm at the university, and Gborgbortsi is very much aware of where I am and what we can do with this kind of training. It's very important. I'm very much interested. So I need to know much about how this is organized, and so that we can be part of the process and then get the people prepared for this training. Over. So if Gborgbortsi can give me some more information about this, I'll be very much happy. Winfred?
Yeah. So,
but probably I'm sure Winfred will take it forward. I mean, have specific engagement. Of course, the idea is here to have the specific connection with the right person and also with the right team, because the Southampton team have a very strong team working in some countries. I think Winfred could take it and maybe engage further with the local team into exactly how to more take it forward. But I've seen some other questions that are very important there on the chat also about like I've seen this one from Ashenif, Ethiopia, with asking whether there's any possibility to use some pocket survey data for this as an input. Maybe I'm not sure whether I understand the question, but he could chip in if you want to clarify. But if you understand the question, Andy, maybe you could also take it. And others are talking about need of really being trained on specific GIS basics. They also probably maybe you want to say something before we move on. I'm not seeing any other question here.
I'll just help Andy and in answering the first one that you mentioned. Yeah, so there is possibility of using such data. So one of the examples that we showed earlier, you'd see that we combined the DHS survey with routine data, where routine data indicated for us where specific services were happening. In addition to that routine data, you could also add other attributes as to the number of midwives, the number of delivery beds, the type of services. So you could make it a whole service availability and readiness assessment survey. And then you can combine that with the DHS survey. So if you take a cluster, you could start estimating what is the nearest quality, or if you aggregate all the quality near a cluster, what is the level of quality that you can find. And then you can now link this type of quality to utilization. So in that result we showed earlier, the clusters that had hospitals, very good quality facilities near them, were having more than twice the probability of having a skilled attendance at birth, compared with clusters that had either very poor quality or no IMONC facility at all. So yes, it is possible to combine such data, and you can reach out to us to further such analysis and discuss ideas.
Okay. Yeah, I think that's quite important. And as I mentioned, there may be several interests from different countries, and I've seen this question from Ethiopia also about what do you mean by GIS program, but I think those are basic. I think any of you could answer that. But there's a question I'm not sure whether also we've answered about. I think this is from Advocacy. Can you give example of how some of this data have been used at the country level? But I think I'm not sure whether you provided those examples. But if you maybe spend a few minutes on that, that would be helpful before we wrap up.
Again, oh, sorry, Andy, you were
go ahead. You go ahead first.
Yeah, so again, I came from Ghana Health Service to Southampton. So a lot of my research has been in very close collaboration with the Ghana Health Service. In terms of the planning, we have local people on the ground who assist in who collaborate on the research I do, and we do as a group. So in that respect, some of the findings that we find in terms of the bypassing, in terms of the probabilities of birth, we have people who are translating this into action on the ground, where they try and formulate policies based on some of these findings that we have. So it's very much being used on the ground in Ghana.
Yeah, and there's multiple examples as well in the use of the population data for guiding health interventions like vaccination programs, distribution of bed nets. These approaches are seemingly, in some cases, producing more detailed and up-to-date population data than often exists when a census has been done 10 years ago and there's been a lot of change in the country. So they've been able to then reach the target level of children that would have been missed had the old census data been used. So there's a set of examples there as well that we can again post on our website, and happy to answer questions as well about country-specific needs.
Okay. So I think that's quite interesting, and I I see some of those questions in the chat have been perfectly answered. And I'm sure there will be further engagement and there will be also more workshops. This is just the first one, as we mentioned. I think this is the first one, just to show you what is possible, what could be done to inform the reviews. And all these materials are available. I think Britannia may have shared the link or will do it very soon so that you could also access all these materials. But the most important is for the countdown technical lead for this country, depending on whether this is really needed or not, to now concretely engage with Andy and team into exactly how to get there. And I talked about Cote d'Ivoire, who really was expressing a need now, and also other countries you mentioned. I think there will be further discussion, and then the support could be provided through those channels, and we could see now what next. But I really like to appreciate this. Maybe in terms of way forward and next, what Tis could mention anything to close, to wrap it up before. I think yeah, we are there. Tis?
No, thanks, Sheikh. So thanks a lot, Andy and Natalia and Winfred. That was a great input, and I think we are all hungry for more. So this is the third Data and Analysis Center presentation. So the fourth will be in 2 weeks' time, and that will be on health financing, presented by the London School team. So thanks everyone for joining us, and see you next time.
Thanks a lot, Tis. Thanks everyone. Thanks Andy and team.
Thank you.
And we look forward to seeing you in 2 weeks' time. Thanks a lot.
Thank you.
Great.